Good evening, everybody. Welcome to this month's CMT webinar. So glad you could join us this evening. We're very fortunate to have Dr. James Nussbaum with us, who is going to be speaking on the importance of properly measuring functional movements related to mobility, strength, balance, and activities in daily lives of people like us with CMT. I've had a few minutes to talk with him offline. I think you're going to find this presentation very informative and very helpful. Before we begin, I do want to say a couple of things. On the right-hand side of your screen, you'll see an area there where you can ask questions and or ping me if you have any in particular questions you want to email me privately or IM me in the chat window. So if you have questions during the presentation, please type them in the question window, and then I'll come back and look at those. Dr. Nussbaum has been kind enough to say that if a question applies to a particular slide, we may stop and handle that question right there. Otherwise, we'll take things off at the end of the presentation. So thank you very much for all of that. And with that, I'm going to turn it over to Dr. Nussbaum to begin tonight's presentation.
Bob, thank you very much, and thank you all for the opportunity to speak with you this evening. Particular thank you to Mrs. Beverly Wurzel, who really introduced me to the CMT community a number of years ago. And thanks to all the terrific people at the CMTA who work tirelessly to help the community. One shout out, support the CMTA. There's so much to be done, not only for the future, but for the people currently affected by CMT. And it doesn't come without cost. Last year I had the pleasure of heading out to Cedars-Sinai in LA to share some of my ideas and to get a better understanding of some of the great things that their team is doing, and it all costs money. So help by supporting the CMTA. I know there's more that we can do, and it would be great to start doing it with some more funding. Tonight I'll be talking about the importance of using specific functional assessments to enable more effective treatment and monitoring of progression in patients with CMT. I firmly believe that every patient with CMT should be evaluated by a skilled physical and occupational therapist. Just a couple of years ago, I had the opportunity in the same venue to speak about skilled physical therapy and exercise to improve function and quality of life for patients with CMT. And interestingly enough, what I really spoke about, what's underlined, is cardiovascular exercise, resistance exercise, balance, and functional exercise guidelines, and some of the literature behind recommendations. And interestingly enough, it was really kind of backwards, because then I was speaking about the importance of exercise, and tonight we're speaking about how we can measure things. And if you look at the screen in front of you, it says that we'll discuss the importance of properly measuring functional movements related to mobility, strength, balance, and activities of daily living in order to monitor the changes associated with treatment and or pathology, or the progression of symptoms and signs that we might have. And we'll focus on the measurement of gait as a tool to understand where problems or potential problems might exist. So I probably should have had this talk first, followed by the exercise, so we would have a better way of measuring if, in fact, some exercise would be beneficial for us. Over the next 45 minutes or so, I'll give a super short background about CMT, about myself, and then we'll define some terms. We'll discuss a little bit about what the medical literature has to say. We'll get more into measurements, particularly gait, and then we'll summarize. As Bob said, we'll certainly have a chance to address some questions, and go ahead and please feel free to shoot them forward, and if I can comment on them at a particular time, I certainly will. We'll have about 10 or 15 minutes in the end to answer some questions and to be a bit more interactive. I am not a world-renowned expert like Dr. Shai or Gita Randhari, or many of the other true experts here in the U.S. and around the world. As I told Mrs. Wurzel a number of years ago and some of the people at the CMTA, I'm just a simple physical therapist who's interested in improving patient-centered outcomes. And the patient population is almost irrelevant, certainly in a general sense. It's really just trying to educate the patient and the medical community on the importance of proper measurements, then measuring again to better understand the impact of time, progression, and treatment. So whatever I we'll be talking about over the next few minutes is my opinion, and there are those who may disagree with me. I will cite some literature, and we can blame the authors of the studies that I cite. Tests, exercises, activities should be cleared by an expert, by a physician. Consult your physician prior to engaging in any new activity, and you can certainly ask your physician to speak with another expert. There's no sponsor for this talk, and unfortunately, I have no interests to disclose. So I've had an interesting personal background coming from a variety of places. You can read this another time. The bottom line is that I've had the privilege of working with some very smart and accomplished people over the years and have been honored by being invited to share some of my work throughout the United States and the world over the last few years and having the opportunity to present at different conferences. That was the view from my window at Johnson & Johnson a number of years ago. So, Charcot-Marie-Tooth, 2.8 million people or so are affected. How many are diagnosed versus affected? I'm not sure that we know. More than 120,000 Americans. It's an inherited neuropathy, something you're born with. It's not something that you get, and there are more than 70 varieties. This information is off of the CMT website. We often see foot deformities, foot drop, foot slap, and muscle atrophy or muscle loss in lower legs and hands, numbness in the extremities, and people often have poor balance and mobility issues. We won't be discussing genetics, pathogenesis, or the way in which people ultimately manifest what we find with CMT, and none of the underlying issues that ultimately lead to someone being diagnosed with CMT. That's for people much, much smarter than me. I firmly believe that the primary goal of healthcare should be to improve quality of life. So what impacts quality of life? For many of us, it's being independent, it's being a little bit mobile, certainly being just comfortable, not in pain, and having some control over our lives. Each specialist plays her or his part in working with their patients to be able to improve quality of life. So I wanted to define some terms, and of course I went on Wikipedia. Where else would one go for a definition? And I looked up functional assessment. Did not find anything. Functional tests was quite close, and it said functional testing is a quality assurance process and a type of black box testing that bases its test cases on the specifications of the software component, and then I stopped reading because this has nothing to do with what we're talking about. So I decided to make my own definition. And I defined functional assessment as tests and measures, preferably objective, valid, and reliable, related to one's typical daily tasks and activities. We want to assess things that are meaningful, assess things that are functional, assess things that have to do with the things that we want to do in our lives. I particularly want to define fall as the World Health Organization defines it, as an event which results in a person coming to rest inadvertently on the ground or other lower level. Interesting definition, because according to that definition, we probably all have many more falls than we would care to admit to. But given that imbalance is such an important issue for many people with a diagnosis of Charcot-Marie-Tooth, I felt it important to define fall. As we go through some of the literature a little bit later, we're going to hear words like objective, valid, reliable, sensitivity, specificity, normative data. Something is objective when it's true, it's fact, it's not subjective, not something that I think. When we talk about something or a test being valid, does it really measure what we think we're measuring? If it's reliable, we'll get consistent results all the time, whether or not it's right, but at least they'll be consistent. If something is sensitive, it'll be able to give me the percentage of sick people or correctly identify those that are sick amongst the population, for example. And if it's specific, it'll be specific enough to identify the healthy people and identify those as not being sick amongst the population. A little bit confusing. When we talk about normative data, or what we expect, how someone might perform on a particular test or measure, what's very important to think about is for what population. So if I take a look at a test and see how fast 8 and 9-year-olds typically eat a bowl of cereal, well, that might be one way of measuring the normative data for that population. But if I now make it an 80 or 90-year-old, maybe that population eats a bowl of cereal a little bit slower, a little bit faster, and so on. A little bit more on reliability and validity, and we'll get away from some of the statistical stuff in a moment. But if you take a look at the top left of your screen, the shots, if you will, are kind of all over the place up top, and it's not giving me much information. It's unreliable and it's not valid. If you go to the bottom left, it's not going towards that bullseye there, but it's pretty consistent. So I would call that reliable, but not valid because it's not going towards that bullseye like I think it should. It's only in the bottom right when I'm getting consistent results or reliable results, and valid because as I look through my hole, I'm actually getting to the bullseye. If we go in more layman's terms and something that might be more meaningful to all of us, at the end of the day, if we're going to look at an assessment or an outcome measure, something that we're going to measure to see how we're doing, we want it to be quick. Nobody wants to go through tremendously long testing. We want it to be cheap because if it's terribly costly, both myself, the provider, and or the patient, if the cost is passed over, not necessarily going to be willing to do it. We want it to be painless if at all possible, certainly feasible. We can have great plans, and if they're not feasible, they'll never happen. And we want the results to be meaningful. We want to be able to get something out of it that's going to mean something for us. When we talk about normed data or normative data, I would argue that very often I more so care about me versus myself. If I'm diagnosed with CMT today and I have an opportunity to go through some outcome measures or some assessments and see where I do and how I'm doing, and then I get a chance to do some of those assessments again in a month, in 6 months, in a year, in 3 years, I can compare how I'm doing myself, and I know what I might have done to potentially help myself. And I can get a sense of how some of the treatment might have affected the results of this test and how some of the progression, if at all, of the disease may have affected the results of these tests. So it's therefore important to establish a baseline, even if there's no normative data, although there's some, and to enable objective benchmarks over a period of time. We often hear, why bother? I actually got a question from one of you, I believe, prior to my talk, and saying, why do doctors want yearly EMGs and nerve conduction tests when there's no treatment for CMT? And you could kind of say the same thing to what we're talking about here tonight. Why keep testing if there's nothing that we can do? Well, I think there are certain things that we can do, definitely nothing that's curative or magic or anything like that, but it's important to see how we're progressing or regressing, and there might be certain things that we can do based on some of the things that we find with some nice testing. So what does the literature have to say? Well, if you take a look on PubMed, which is the way that I like to look at medical studies, and you put in assessment and stroke, you'll get over 27,000 citations. That's a lot of literature to go through. I'm happy that we're not talking about stroke tonight. If you put in assessment and multiple sclerosis, you'll get almost 4,000 citations, 3,893 citations. If you put in assessment and Parkinson's disease, you'll get 3,753. Quite a lot of citations. If we put in just assessment and neuropathy, general neuropathy, nothing specific, we'll again get over 3,000 citations. Putting in assessment and CMT yielded 115 citations. Again, that's some literature, and for any of you familiar with PubMed, you'll know that how you in fact look at things often can change the results that you get. So you need to be creative sometimes in looking. But obviously, as you can see from this slide, all of these things are neurological conditions, and the assessment in CMT is not as easy to get information as it might be for some of the other problems and diagnoses that you see here. Certainly, in going through the literature, there are people that are experts that are people that are out there. They're people that have done tremendous work for the population. And if there are any of you that want to take a look at some really solid research and some good literature, these are some of the names to go ahead and look up. I'm going to highlight a couple of quick studies just to show that what I'm talking about tonight is not my own idea. I'm not so brilliant to have come up with how important it is or why important it is to assess people. I'm going to try to convince you all that doing particular tests, specifically gait analyses, are very feasible, are very quick, are painless, and therefore very, very good idea given that they yield some good results. But there are numerous measures out there that take part of a variety of assessments, such as just recently in June in the Journal of Neurology, Neurosurgery, and Psychiatry, they took a look at and they attempted to develop and validate a reliable patient-reported scale that grades the severity of disability in CMT from a combination of an in-depth analysis of the patient's and provider perspectives on what mobility changes constitute the severity of the disease. And there were 259 respondents, 92 healthcare providers, 167 patients, and they concluded that there was perfect agreement on qualitative descriptions of disability between the patients and the providers, which is excellent. And in fact, there were significant differences, however, in quantitative responses on items corresponding to minimal or severe disability. Yet it was still a very important paper, I believe. Dr. Shai and colleagues in a seminal paper in 2005, already 10 years ago in neurology, looked at the reliability and validity of the CMT neuropathy score as a measure of disability. And what they did was they devised this from the TNS, from the total neuropathy score, and they made a single measure to quantify CMT disability with 60 patients. And again, it was a terrific result, and in fact, it's widely used today. Just recently in the Journal of Hand Therapy, they looked at the reliability and validity of a particular test to measure hand function. And in fact, they found it to be reliable and looked and very positively looked at everyday tasks in patients with CMT. Without boring you with too much more of this, this is an interesting one looking at the pediatric scale. And again, of course, Dr. Shai is there. And what we see here is a pretty busy slide with lots of different things. But if we look at it a little bit more clearly, there's demographic data. It talks about symptoms where people can check off certain tests and measures, sensation, foot postures, hand dexterity, grip, 9-hole peg test and range of motion, quality of gait, a long jump, a 6-minute walk test, which is really a cardiorespiratory test of gait, and the Brunix, which is a very famous pediatric functional scale. Just this past May, in a systematic review of exercise for patients with CMT, they looked at every article they possibly could look at, and they came up with 13,000 articles identified for exercise in CMT. But after they took away duplicates and did their inclusion and exclusion criteria, only 11 articles, including 9 unique studies, ultimately met the criteria, which is pretty interesting given that they started with over 13,000. And they found that, unfortunately, the methodological quality of the studies was moderate, the sample sizes were unfortunately small, and the interventions and the outcome measures varied widely. And the reason I bring this up is because those outcome measures varied widely. And in my limited personal experience of seeing not even 100 patients with CMT, just a tad less, most of the patients that I've seen have not had some of the more famous tests and measures, or at least they didn't know about it and they weren't available to me. In a study that I'm working on right now with an oncologist here in New York, we're looking at quantifications of impairments in chemotherapy-induced peripheral neuropathy. Obviously, this is different than CMT. This is something that is induced. It is not something that is hereditary. But we're looking at the spatiotemporal gait characteristics, mobility, activities of daily living and quality of life measurements, and we're finding some really, really interesting things, some of which I think carry over to the CMT patient population as well. In a study that we completed here in New York in my office about a year ago or so, that we're having the opportunity to present at the Combined Sections meeting in Anaheim, California, early next year, we looked at the effects of usual footwear on gait and dynamic balance in community-dwelling older adults. Unfortunately, our sample size was small at 27, and interestingly, we found that despite wear and tear, having shoes on, your comfortable shoes, seems to improve the quality of some gait parameters versus walking barefoot. And I put this here because very often when we look at gait, when we look at the way people walk, we might have them in their shoes, we might have them barefoot. And there are those that say, oh, we should have everybody barefoot if possible, because that limits some what's called extraneous variables, the different type of footwear. And others say, well, how many people walk around barefoot? We might be wearing braces, we might have our shoes on, and they provide support, which I think we proved in our study. But interestingly enough, we found no significant differences in dynamic balance between the usual footwear and barefoot conditions. However, with gait itself, we found a significant difference. In another study, very, very recently, this past summer, the custom-made insoles dispersed some pressure concentrated by some of the arch changes that we see in patients with CMT, and therefore they concluded that it could help patients walk by offering some support, by preventing some of the deformity or the high arch that many people have, and dispersing some of those forces and relieve the burden and fatigue in the lower limbs during gait. In a study just a couple of years ago of unfortunately only 8 participants, they looked at outcome measures very related to what we're talking about tonight, and rehabilitation treatment in patients with CMT. And they found that very, very nicely, ankle range of motion improved and the time to walk 6 meters improved, although some of the other things that they looked at did not improve. In a recent study by Gait and her colleagues, they concluded that AFOs can reduce foot drop in some patients and remove the need for some proximal compensatory action. Proximal compensatory action in English means things that are higher up that you might do to help a problem that's going on down below. So if I have a problem down in closer to my feet and my ankles and my lower legs, and I might therefore need to do something up near my hips and knees to help that, they found that the particular AFOs, and they looked at 3, managed to do so. So we looked at a lot of literature. For some people, that's super exciting. For others, it's incredibly boring. So I'm personally happy to get past it with you here tonight. The goal for most people is to try to be as independent as possible, to be tolerant of activity, to be safely mobile if at all possible, to participate more in activities of daily living, to even participate in recreational activities, and really to give ourselves choices. We want to choose what we want to do. You don't want to be told you can't or not be able to do certain things. Who are the experts in testing and improving function? I will not so humbly say occupational and physical therapists for the most part, along with the neurologists and other people involved in the care. Within our organization, when we have a patient with CMT or most peripheral neuropathies, we do numerous tests. Or outcome assessments, functional assessments. Our occupational therapists will administer something called the SF-36, and that's the gold standard quality of life questionnaire. It has 36 questions. We will give the upper extremity functional index, a bunch of questions asking how you do with different activities. Is it impossible? Is it very hard? Is it moderately hard? Or can you do it pretty easily? The dash is the disability of the arm, shoulder, and hand. The Purdue is like a dexterity test where one needs to put little pins in little holes. The Barthel Index is a way of measuring activities of daily living. And can you put on this sweater? How do you do in the bathroom? And so forth. Grip dynamometry is when you squeeze that funny machine that some of you have had the opportunity to squeeze, and it gives a measure of pounds per square inch, and it can be done with gross grip or the whole hand squeezing. It can be done using 3 fingers, and there's some other ways in which we do it. And something also called the 9-hole peg test, which is also, you'll have a chance to see a picture in a moment. There it is on the left-hand side. There are some norms, meaning expected times to complete the test, and there are, of course, papers on it, like there are for many, many, many of these things. From a physical therapy perspective, and what we do is we look at the spatiotemporal gait characteristics, and we'll talk a lot more about it in just a few minutes. We do a test called the Dynamic Gait Index, which measures how you do under a variety of conditions. We do the Berg Balance Scale, which is really assessing falls risk and how people manage to balance in a variety of activities and positions. The Timed Up and Go, which you'll have a chance to see in a little bit. And a lower extremity functional test called the Sit to Stand, and we see how many repetitions someone can stand up from a sitting position on a chair that's a standard chair of 17-inch or 18 inches in height, with their arms across their chest or not using their hands at all to stand. So that Timed Up and Go tests dynamic mobility. First, you have to transfer or go from sitting to standing out of the chair and ambulate 3 meters or about 10 feet, turn around, a 180-degree turn, and then return to sitting. And this is done at a self-selected speed, meaning go ahead and please do it in a normal manner. If you use a cane, normally you can use your cane. If you use a walker, you can use a walker. If you don't use anything, then you don't use anything. If you wear braces normally, you can wear your braces. And sometimes it's interesting to take a look at with and without braces, with and without a cane, with and without a walker, with and without shoes. Matter of fact, New York City even promotes the use of the tug as a very, very quick and easy measure of function and dysfunction and of falls risk. And what you can barely see on the bottom of that slide are some of the norms associated. So if we take a look at one of the tests, which is the Timed Up and Go, which is a widely used test. I had a patient today who was nice enough to give me permission to use her for the film. And in fact, I'm going to have a chance to hopefully show you what it looked like, or maybe not. Practice makes perfect, doesn't it? Sorry, folks. So take a look at this nice young lady over here. So if you see straight ahead of you, you'll have a chance to see red chairs. She was asked to stand up, walk towards us. Sorry for the background noise. Asked to turn around that post-it that's on the floor, and then return back to the seated position. Let's take a look at that one more time. I had to cut it in order to get it onto the computer. I apologize. If you take a look right here, she's using her hands. That's a no-no. So she's unable to stand up without her hands. So therefore, when we document it, this is a modified test because she could not get up out of the chair without the use of her hands. So there she is. She gets up. She holds onto her walker. She gets no instruction on how to do it better or faster. She turns around the marker, and then she returns to the seated position. That's the tug, the Timed Up and Go. When we look at impairments and deficits that seem to be prevalent, whether it's pain, fatigue, weakness, muscle loss, sensory loss, imbalance, falls, joint deformities, autonomic dysfunction, which is trouble regulating temperature, trouble with blood pressure, lability, or inconsistent blood pressure that some people have, and some of the comorbidities, because what I like to always say is that unfortunately, just because you have CMT doesn't mean that you might not have other things going on, some spinal stenosis, some knee pain, some neck pain, who knows what might be going on. And of course, we all need to, as providers, need to see patients as a whole and assess them functionally as a whole. So the impact of some of these deficits and some of these impairments, of course, play into function, play into independence, and ultimately, of course, quality of life, which is our ultimate goal. Okay, that's a fancy bridge somewhere in France. So let's talk for a few minutes about spatiotemporal gait characteristics, specific parameters of human gait. And this is extremely important and what I want to focus on for you. In an article some 30 years ago in Clinical Orthopedics, they were looking at the pathogenesis of CMT, kind of how did all these problems start, and they wanted to look at gait and some electrical findings, genetic findings, and other things to get a sense. And they found that the gait pattern that they looked at in a few of folks from a particular family, there was 22 people and 12 demonstrated what we're about to read, the gait pattern had a greater complexity than just the steppage gait, or the gait where people kind of lift their feet and their knees up high if they have a drop foot or if they don't control their ankles so well. They found a pelvic shift and elevation on the swing side, which we'll talk about in a moment, to clear that drop foot from the floor. And they moved their trunk to the side, to the opposite side, in order to try to stay balanced. And I think this is a very important thing and something that we read in some of the literature before about compensations and what we talked about of proximal compensations for distal problems, meaning if just because the problem is down below for some people, that doesn't mean that we're not going to do some things up top, particularly at the hip and the trunk. So we use a laser gait analysis in our clinic to measure what's called the spatiotemporal gait characteristics. And without using the fancy language, it's a laser system that measures a lot of different things. And it's a two-dimensional gait analysis to objectify, to give us fact on what we think we see when we're looking at people walk. It's nice enough to take a constant mean. It's constantly averaging what's happening. And we can see a variance over time, which is important, so that if I'm walking and I take a funny step, and if I take a really funny step, and while I'm taking that funny step, it messes up all of the information that I was previously getting because all of a sudden I did a funny thing. Well, I don't want that funny step to kind of give me false information. So what I do is, it's a constant mean, a constant average, so it means almost nothing in the grand scheme of things. So what you see in front of you right now is what my computer looks like before the person, or in this case, before I start walking. And you can see over here that this is all empty, but there's a lot of numbers and categories and all kinds of things. And we'll talk about them in a minute. Here's the track that I'm about to walk on. And this track is about a 20-foot track, 20 feet long, about 5.5 feet wide track in my office, and the patient just walks normally. And what you see here in green and these circles, these are just all little lasers on the floor, and you'll get a chance to see soon on what it looks like. And as I walk, the data starts to fill up over here. And there are my footsteps, and as I start walking through the pathway, everything starts filling up, and all those colors and all those numbers and all that data. And I can watch as I go, and I can see my line of progression. I can see my step length over here, and it's giving me variance over here. I can see my step width. I can see different phases of the gait cycle. I can see times and pre-swings and loading responses and things that might not be so meaningful to you all right now, but I'm going to highlight the 3 things that are meaningful to us as we go through these gait analysis. And it literally takes about 2 or 3 minutes to do this, and the patient is just walking back and forth. For lots of people, we'll do it with and without braces if we safely can, and we always do it barefoot to eliminate some of what we were talking about before, again, if it can be safely done. And we ultimately get a report, and the report looks like this. And it has my name, and it has when I took the test, and it has a lot of information here. Lots and lots and lots of information, but let's try to get a quick sense of what it might mean to us and why we really care, if we do. We actually looked in our office, as you saw before, as we mentioned before, the people with bare feet versus their shoes, and we found some interesting information. But some of what we get with this is the same report that you just saw before. If you look a little bit closer, and I think you can see it now, one of the things that we get is step length, and we look at it left versus right, but also we want to see if there's symmetry, and we also want to know the total absolute number. Does it fall within where we think it should fall based on the person's height, gender, and so forth? We also look a lot at something called single support. We'll talk about that in a little bit. And the speed, which is incredibly important to us. So the speed, or the gait velocity in meters per second, the step length, how far each of our steps that we take are, and single limb support, which is the amount of time during the cycle that I'm on my right leg and my left leg. And again, another sort of confusing slide, but if you see this gentleman here taking a step with his right foot, right now he's in double support, meaning he's on 2 feet. This next slide over here, he's still on 2 feet. So that's double support. And here he goes, he's on 1 foot. So we would call this single support on the right leg. He's still on single support of the right leg. The left's about to come down, and boom, double support again. Now the left is alone, single support, and it's about to be over. In a normal situation, people are in a predetermined length of time in single support. But let's talk more about gait velocity for a moment. Gait velocity is incredibly telling. And gait velocity in my particular test over there, which is pretty slow, and I can have a few potential excuses, my average speed was almost 1.1 meters per second, and that's the low end of normal. But gait velocity has been called a perfect measure by Fritz in the Journal of Geriatric Physical Therapy in 2009. Why? Because gait speed alone, or self-selected gait speed, if I measure your gait speed over a period of time, or excuse me, over a distance, I can predict hospitalization or morbidity. I can predict falls. I can predict if you were to be in the hospital and take your gait speed, what the appropriate discharge location would be. It has the ability to enlighten on functional and physiological changes and actually can predict mortality. It's called a perfect measure by Fritz, and actually they wrote a white paper calling it the 6th vital sign. It's been normalized in many diagnostic categories, but not CMT. It literally takes minutes, if not a minute, to do, and it can measure change over time, quality of life, and like we said, mortality. It has been normed, or they have done the research in patients with multiple sclerosis, with ALS, people with strokes, and I've unfortunately only done it so far with people with confirmed CMT on 31 patients that we have it documented. We have it almost 100 in different ways, but it's not yet published. So do I really care, like we talked about before? Do I care about the norms? Well, it's interesting to know because the different studies look at it in different ways. But because it's so predictive of things that we do care about, I'm going to argue that we do care about gait velocity. And again, this is self-selected gait velocity. Fast gait speed is also important. We measure fast gait speed here as well, but it doesn't have some of the same statistical power. Can I get across the street before the light turns? Obviously, that's an important thing. Let me look at it with and without my assistive device or braces. Maybe I want to try a different brace. Maybe I want to try a different assistive device. The single limb support that we were talking about before is the amount of time that I spend on one leg, and the normal's about 40%. 40% on the right, 40% on the left, and about 20% on both. I'm going to show you a little video now, and you're going to have a chance to see somebody walking, and I want to kind of take a close look at some of the things that we just talked about. So here you see this is slow motion, and now that left foot comes down, and now it's left foot single support. Now it's double support. Now it's right single support and double support. And this is a patient with CMT, and you can see a few things that are characteristic. Sometimes we talk about people with high arched feet, and sometimes we talk about people that have a collapsed arch. And you can kind of clearly see where this patient falls within that mix, I believe. And as they're turning around facing towards us, what I want you to take a look at is that amount of toes that you keep on seeing, the top of the toes, top of the toes, top of the toes, and here it finally comes down. It comes down with a flat foot. Toes, 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 toes. And why is that? It's because there's poor control of the ankle. And we would call that a foot slap, a foot drop. Is it horrendous? I wouldn't say it's horrendous, but look how high the knees come up. And that's that steppage gait that we talked about before. So he's walking here inside of our laser system, and literally it's just a, oh, we're going to get to see some quicker one here. You get to see a little bit more of some challenges that he was having as we go through that. I'm going to take a look really quick at just the very end one more time so you can see a couple of other things. Look how high the legs come up, and this is some of the proximal compensations for distal problems that we were talking about before. If you saw that toe just there, you got to see how that big toe just dragged through, and that's why people sometimes fall and have problems. And it looks a little bit kind of floppy, and that's something that we'll often see. If we look at it from the side, we can see some other things here. And again, we're in slow motion. Let me make it a little bit bigger for you. And you can have a better sense, I think, I'm sorry this one's not as clear, of that drop foot and how high he needs to pick up his legs to come up. Some of you might be looking at this saying like, oh God, I only wish I could walk like that without braces, while others are saying, oh, that poor guy. And of course, we're all different, and we all function very, very differently. So as he walks back forward over here, again, you're going to see that high knee. He's coming with a flat foot. There's no real heel strike, which is what's typical. It kind of all comes down. And he's very, very flat with that arch. It kind of caves down, and therefore has to work extra hard to walk and lift up those legs. So everybody's gait pattern is a little bit different. However, the particular way in which one person does it versus another can really be looked at using this gait analysis system, which, like I said, just takes a couple of minutes to do and provides a tremendous amount of information. Let's see what we have here. So step length we talked about. Normal is 55 to 70 centimeters. And some of the impairments could be due to many different things. And I don't want to go through this too much because I want to save plenty of time for questions. But if I have a decreased step length, and hip flexion, as we were talking about before, is when you lift your knee up high or you bend at the hip while you're walking. And if I don't have good hip flexion and I can't get my knee up, well, then I might not get my foot far out enough. And ipsilateral means on the same side. That's incorrectly spelled. If I don't have good hip extension, if my left leg doesn't go behind me so far, well, then my right leg's not going to go in front of me as I walk. And these are particular things that the therapist can look at by using the gait analysis to really take a particular, careful, objective look on how somebody walks and what they're doing, what they are uniquely doing, and how we might try to help them, and how they might change over time based on treatment, based on progression, based on assistive devices, based on braces. Ultimately, you want to find a CMT center of excellence, and you want to consult with experts and be proactive and not just say, hey, there's not much we can do, so I'm just going to lie in bed all day. As I said before, support the association. Always and ever, usually not good things to say too often. And find some skilled people so that they can evaluate you. I personally believe that everybody should exercise. And certainly everyone with CMT should exercise. I think it's good for everyone at the right time and the right dose, using the right mode at the appropriate intensity with proper rest periods, however, under skilled guidance and supervision. And the only way to know if it's effective for you is to have functional assessments prior to starting and then functional assessments over time, and to see what, if any, changes might be going on. Use the experts in function to do these things. Use OTs and PTs. Of course, in conjunction with your family, home health aides if you have, social workers, your neurologists, your physiatrists, orthopedists, prosthetists, and orthotists. Can't say enough about for patients with CMT, rheumatologists, cardiologists, pulmonologists, psychiatrists, and the list goes on about all the people in the team that when working together can really help to improve function. You should get evaluated. Speak to your doctor. It would be great if you can get evaluated using some of the tests that we talked about, or the measures and questionnaires and assessments that were in the literature, and some that weren't in the literature that we described here today. Well, how much does it cost? Is this going to cost me a bloody fortune? Well, very often, and I'm going to say usually, these things are covered by insurance. But nowadays, who knows what that means? Covered by insurance doesn't necessarily mean anything. My particular insurance plan, I have a $10,000 deductible. So I end up paying for pretty much everything. What is covered? You never know. The healthcare environment, as I think we all know, is constantly changing. But I will tell you, in my experience, every single patient who has insurance that we accept, and fortunately and unfortunately we accept pretty much every insurance, it's covered under their plan. Whether they have a copay or whether there's a deductible is unique to each individual plan. Working together, we can make a difference. Communication is key, doctors, practitioners, and so forth. And I think that through skilled therapy, through measurements with your neurologist, with your therapist, we can certainly help to prevent some falls. We can certainly work to help to improve abilities and activities of daily living, in mobility, in community access, and most importantly, in quality of life. It starts with an evaluation with a functional assessment included, and that way healthcare providers can help to improve quality of life. It's a long road ahead. We've barely begun to understand what's going on with this disease and how we can help it. But I do think that there's a lot more that we can do and that we should do together. We'll open things up now for questions and answers, and I'll do my best to address all of the questions as quickly as I possibly can, and get my slides back up if in fact I have a slide that can address a particular question that somebody has.
Thank you very much, Dr. Nussbaum. We do have a number of questions here, so we'll start with some person here is asking sometimes he feels like he just can't seem to connect to his legs, so that he's feeling like he loses feeling in his legs for just a few moments, but causes him almost to feel like he's falling to catch himself. Common thing or something that you're aware of?
So I'm going to answer it in an unfortunately vague, non-committal way. Like with most things, we can blame this, if you will, on the CMT, and potentially there might be other things going on that could be a part of this. From the pathology, as I understand it, things should be relatively consistent. However, we all know in life things generally are not. So I have heard of people having very similar complaints and similar feelings. Could I completely attribute it to the CMT and understand why it's happening? Not necessarily. For some people, when they don't move too much, there seems to be a disconnect, and very often with movement, with some joint compression, kind of just often weight bearing, there's a little bit more of a sense of connection and a feeling of where my legs are, where my feet are, where my ankles are. But people do say a lot that all of a sudden sometimes they feel as if they're not connected, and all of a sudden everything might collapse. If this is something that happens, number one, I would ask my neurologist. And number two, if it happens to the point of it being dangerous, I would consider an assistive device such that, if not already used, such that a bad fall doesn't happen and cause other damage. Again, I apologize for not a very straightforward answer, but I couldn't give you a more of a straightforward answer than that.
Okay, moving on, we have another question here. Somebody says, do you see any increase in or decrease in people's ability to have a proper gait with lack of sleep?
So, yeah, very, very interesting question. And there's actually a little bit of literature on this, not necessarily in CMT, although it can be in CMT, but I personally didn't see a study on it. But in general peripheral neuropathy, there's a lot, and they talk about this vicious cycle of pain, dysfunction, depression, poor sleep, pain, dysfunction, depression, poor sleep, and it kind of all leads towards stuff that we don't like. However, if we can break the cycle in any one of its points, then we can turn potentially that vicious cycle to the virtuous circle. Can I give you some reasons why poor sleep would decrease gait? Of course. I think we could all probably imagine if I'm fatigued, if I don't feel energetic, I'm going to be a little bit slower, kind of literally dragging myself, and that sort of makes sense, almost common sense, I would say. But from a very, very clear clinical perspective, I'm not sure that that information is out there. However, poor sleep and poor function have been correlated in numerous categories. Some of the research that I've done with patients with kidney dysfunction, it's certainly clear that people who sleep poorly, walk poorly, and are weaker, and so on. So it's not surprising to hear that someone who's having trouble sleeping is potentially performing functionally at a suboptimal level.
Okay, we have another question here about specifically about gait. And is there anything that someone with CMT, I guess looking at the gentleman that we saw the video on, can do to, what have you found that improves the gait sequence for people?
Okay, so a few things, and I think that, and I mentioned it a few times, Gait and colleagues did an interesting study, and there are other people that have spoken about proximal strength. There was actually a study, I believe it was in 2000, and actually the one that Gita did in 2014 was called a pilot study of proximal strength in CMT. And it looked at 26 people, and they found modest improvements in hip strength with a home-based program, but only on one side. And they thought that maybe it wasn't the best program. There were a bunch of studies that looked at what's going on at the hips and what's going on at the trunk, even though we like to always think that in CMT it's all the way down below the knees. So what do? My personal approach for so many people, and this is not to say that we don't do anything below the knees and that we don't take off the braces and work on trying to feel as much as one could feel and move and shift on the foot and the ankle. But particularly with this gentleman and with numerous patients that I'm currently seeing, working so much on hip control and hip strength and trunk control and trunk strength. So for example, if for someone to be an effective, take a look, can everyone still see my screen?
Yeah, yep.
So this is the same gentleman with his braces on. So yeah, before we were in slow motion most of the time, but you see kind of quicker, but he's still lifting those knees up more than typical. And what I want you to look at this next time when he starts to come back at us is I want you to all look at his pelvis. And this is one of the main things that we're doing to improve his gait. Look at his pelvis up here. Look at him flying around. That's, I'm going to say a bad word, that's not normal. That's suboptimal. It takes much more energy, and he's lacking in stability at his hips. So one of the things that we work on tremendously is hip control and hip strength. And that's why it's so important to do some of the measures like the tug and the lower extremity functional strength test of sit to stand. So for example, for him, just a few months back, he could not get up out of a chair without using his hands. He could now do 11 repetitions in 30 seconds. And you might think, well, I don't care about 11 repetitions in 30 seconds, but what we're working on is strengthening his hips so that he can better control his trunk while he's walking. And if he can do that without having to lean so much side to side, he can be more efficient and spend more of his energy going forward versus just trying to hold himself in space. So by working on, and that's just one example, particular areas of strength, of mobility, one can really make a significant improvement in gait. I see that there's not so much time, but I'll give another very, very, very quick example. I had a patient a while ago who couldn't decide if he should get braces or not. And he only really started getting symptoms in his 40s, and he wasn't sure what to do, and he wasn't telling anybody that he had CMT, and for him, just trying to improve ankle range of motion just a little bit enabled him to kind of go forward versus being stuck and stopped each time because his ankle wouldn't bend. So doing something like a gait analysis could actually help us not only establish a baseline and then a benchmark later on, but could help us focus on an intervention that might help person A versus person B. I know that's not, well, hopefully that was helpful.
Actually, very much, even for myself. You gave me a couple ideas to try.
Okay, good.
This other one, there's a question here. I guess not everybody is in the New York City area. So one of the frustrations is trying to find, a physical therapist or someone who can work with them and get across these ideas. So how would you suggest approaching that conversation, and what are the main things that someone should bring to their physical therapist to say, hey, these are the things I'm trying to do?
So it's very, very hard for me to answer this question, and this is how and why I'm even speaking with you today. I became a perceived expert in CMT. I am not an expert in CMT. What happened was I had a patient, a very nice lady, and she was a support group leader somewhere, and she did well, and kind of I had some good ideas for her, and then she's like, oh, you're not going to believe it, and she told some of the folks at the CMTA, and then I was talking to them, and what I got, unfortunately, from the folks at the CMTA was that so many of the therapists around the country are treating patients with CMT as if they had a sports injury. And of course, it's very, very different. But it's hard for me to believe that some of my colleagues are doing things like this. I think that there's a lot of issues that typically present themselves for someone that has CMT. But to go ahead and to tell your therapist what to do is not often received so well. So I think that what might be a good idea, if someone can go to a center of excellence, or if someone can go, even if it's once or every 6 months, to someone who can take a look at them in a certain way and measure certain things, then in a professional, humble, friendly way, the different clinicians, whether it be a neurologist, an orthopedist, an occupational therapist, a physical therapist, a prosthetist, orthotist, can communicate with someone maybe more local to the patient and make some nice suggestions. It's very hard to go to the doctor and say, hey doc, do this test, and this test, because it's often, as I said, not so well received. Unfortunately, as you saw, and as you probably, many of you know, it's not everybody knows so much about CMT, and to find people that can work with you very well is not always the easiest thing. But I think that the basic underlying principles of what to do and how to do it safely and properly, most therapists should be able to manage. Some of the testing they might not, because they might not have all of the things. I kind of hit it earlier on when I was saying cheap and feasible and easy, but that laser gait analysis system costs about $25,000, so it's not necessarily found all over the place. So sometimes for something like that, it's really nice to get the test done and then work on treatment with someone closer to home. Again, it's not an awesome answer or suggestion, but I think being communicative but understanding that telling someone what to do when you might not be that expert or come at it with, from the proper perspective, always, you want to make sure that it's received well so you can get the outcome that you want to get.
Excellent. Thank you very
much.
At
all helpful?
Yep. We are at 9 o'clock now, and If you don't mind, I'm going to take one more question here.
I don't mind at all, but I just want to say before you say the question, and again I want to thank you all, and particularly Bob, for the opportunity. But afterward, if there are questions that we did not get to answer, if it's at all possible, I would be happy to attempt to communicate, give some answers afterward via email or whatever it might be, and we can discuss that off webinar.
Thank you for that.
Sure.
So this last question is with long-term LE atrophy caused by CMT. How effective is strengthening for gait movement?
So, okay. So we spoke about a bunch of those things a couple of years back, and some of you might be familiar with the concept of overwork weakness, which is a concept that was described, I think, first in the 50s, of potentially people with neurodegenerative conditions. If you work a little bit too hard, you might actually cause the problem to get worse versus to get better. I personally feel that you can really strengthen safely as long as it's monitored in almost everybody. You can't always make improvements, and that's really what the question was. For long-term atrophy, how could you make improvements? I think one of the most important things is if you assess properly, you can identify things that might be more amenable to treatment. So for someone who has just almost no connectivity, for example, to their ankle, and they can't lift their toes off the ground nor push their heel off the ground, and they have no what we call dorsiflexion or plantar flexion. And I think that unfortunately so many patients with CMT have become pretty educated in some of these terms, so I hope that I'm not using them in a way that's confusing. But someone who really can't move their foot at all anymore and whose lower legs look super, super, super skinny due to atrophy. Well, we might be able to now teach them and strengthen the muscles around the knee a little bit and or the muscles around the hip a little bit so that they could still walk relatively functionally. I had a patient, actually I haven't seen him in a little bit, I hope he's doing okay, who had tremendous, tremendous distal weakness, almost nothing going on at his foot and ankle. I would say even nothing. Young gentleman, however, as diligent as one could be, and he worked really, really hard through his hips. His actually knees, he didn't have so much muscular activity, and even his trunk. So for example, if I learn how to use my trunk to be a little bit more stable as I walk, then even with limited hip function and hip motion, I can kind of spend all that energy for propulsion versus stability because I'm gaining the stability with my trunk. The answer to the question is, if I do a really good assessment, I might find something that's amenable to treatment. And again, not magic, it's not going to get to be perfect, but I might be able to get it a little bit closer to functioning the way I want it to than it did otherwise. Every case is, of course, different, and that's what everybody loves to hear. And long-term atrophy is not going to suddenly turn into muscle growth and muscle function, but just trying to find through careful assessment where I might have an opportunity to help someone improve, I think that's the key.
Thank you very much. So with that, I think we'll call it an evening on this one. I'd like to remind everybody these webinars are available on the CMTA website. They normally appear about 3 to 5 days after the webinar takes place, and all of our past webinars are there. And as Dr. Nussbaum said, the CMTA website is just a wealth of knowledge and materials for you to look at. And with that, I'll say thank you very much. Dr. Nussbaum, you want to say a few closing words?
Just again, thank you so much to everybody for the opportunity to speak with you. I'm certainly passionate about assessment and intervention to try to help. There are a few centers of excellence around the country. That doesn't mean that there aren't folks close to you that know how to help you, and hopefully you can find them. But if you have an opportunity to go to a center of excellence and even just get some information and then potentially correspond with them over a period of time. I was warmly welcomed in Cedars-Sinai when I just showed up, and they had absolutely no idea, nor should they have, who I was, and had an opportunity to speak with the neurologists, had an opportunity to speak with the therapists, with the orthotists, take a look at some of the stuff they were doing, and it's really, really interesting. Are we going to all of a sudden have a magic cure tomorrow? No, but I think through the CMTA and through the work that's doing through STAR and all the other initiatives, we're really getting somewhere. And I encourage you all to stay active, stay educated, and don't just sit back and say there's nothing we can do. Go ahead and be proactive about it, and hopefully we can all have some positive change. Thank you so, so much again, and I appreciate the time.